Thank you very much for the kind introduction, and thank you for inviting me to deliver this lecture. And my topic is optimizing amblyopia management. Amblyopia, actually, it was I came across that the name was used by Hippocrates, and it was actually he has said it's a condition which that resulted in decreased visual acuity in a seemingly healthy eyes, because externally the eye looks healthy. And it occurs when there is a major difference between the two eyes in their ability to focus. So we diagnose amblyopia in any child who has visual acuity in either eye of 6/12 or less at age of 3 to 5 years, or 6/9 or less at the age of 6 years or more. And when there is a two-line difference in vision of the two eyes, and they are diagnosed as amblyopic by these criteria. And the incidence of amblyopia in a country, actually this study was done in North America, and they said the incidence is 2 to 4% of the population. So amblyopia is the most common cause of reversible vision, reversible vision loss, if an appropriate stimulation, visual stimulation is provided during the sensitive period of visual development. I think I'm highlighting this, this is a reversible vision loss, which should be done in the appropriate visual stimulation should be done during a sensitive period. So that's why we should not miss it. And so in addition to the low visual acuity, they also have a decrease in contrast sensitivity, reduced vernier acuity, and the spatial distortion, as well as they have low form sense. And in an adult person with unilateral amblyopia has 3 times greater risk, but when it's a child, the 17 times that of a normal person to develop decreased vision in the better eye. And so there is what is called cortical plasticity. In a child, brain maintains high degree of cortical plasticity until the visual maturity is around the age of around 9 to 10 years old. That is the time that we should pick up and treat these children. And but I think later on there are new studies coming up, even in adults who are having amblyopia are treated now with the newer methods. And visual plasticity actually is easy to correct the vision loss, and that is visual plasticity is inversely related to the age. So therefore the treatment should be at a younger age, and so it's going to be more effective if you start the treatment at the young age. So studies have shown that occlusion and atropine therapy can be effective even in adolescent children, especially if the amblyopia has never been treated previously. And there are new treatment modalities like dichoptic therapy and the vision therapy. And they have proven that even it can improve adults who are having amblyopia. And there are actually, first you have to diagnose what type of amblyopia it is, whether it's a visual deprivation amblyopia, refractive amblyopia, or a strabismic amblyopia. And out of these three, actually visual deprivation is the worst amblyopia, is because it's the most difficult to correct, most difficult to tackle. And so it takes a longer time if there's a visual deprivation amblyopia to improve the amblyopia. So we have to catch them early and treat them early. And so when you take the refractive amblyopia, uncorrected refractive errors are considered the most common type of common cause of the amblyopia. And there are 2 main types of refractive amblyopia. One is anisometropic amblyopia, and second one is isoametropic amblyopia. And anisometropic amblyopia occurs with when there's, I think Dr. Manoj also come across, he was discussing this topic. And it is in when there is anisometropia, that is when there is a hypertropia between the two eyes, when there is a asymmetry between about 1 to 1.5 diopter sphere, hypermetropia. And when it comes to astigmatism, when the astigmatism difference is 2 diopters or more, or when it's myopia, it is 3 to 4 diopters difference between the two eyes can cause amblyopia. So, isometropic amblyopia occurs when both eyes are amblyopic from a significant yet similar refractive error. So, severity of the refractive error and the amblyopia are directly related. So, when the refractive error is higher, the amblyopia density is also higher. And bilateral or isometropic amblyopia may occur in the presence of 5 to 6 diopters or more myopia, or 4 to 5 diopters of hyperopia, and 2 to 3 diopters or more of astigmatism. So, there's amblyopia caused by the astigmatism is called also called meridional amblyopia. So, actually, the recommendations for the care of these patients, they are saying treatment of refractive error alone can improve visual acuity in children who have anisometropic, strabismic, or combined amblyopia. So, visual acuity of children who have bilateral refractive amblyopia can also substantially improve with the refractive correction alone. So, there is a chart actually, like Dr. Manoj said, this is depending on the age, refractive error, depending on the age, how much you are going to correct. I am not going into that is because I think my next speaker will be talking about this correction of myopia and all that, how to correct it. And when it comes to strabismus amblyopia, when it's a strabismic amblyopia is there, there is suppression of the deviating eye. And constant strabismus lead to more severe amblyopia than the intermittent strabismus. So the optimal timing of the strabismus surgery, actually we have to decide with the individual. It should be an individual decision when it should be done. And visual deprivation amblyopia is the most dense type of amblyopia. They are due to cataracts, ptosis, corneal opacity, and the vitreous hemorrhage. So visual deprivation amblyopia is the most difficult to handle, and it should be done, actually we should correct them early to have good results. And there's what is called reverse amblyopia. We have to remember when we are doing the occlusion or the penalization of the sound eye, so they can go into amblyopia. So when we stop patching, or when we do alternate patching, it will, when you stop eye drops, it may improve the vision. So the basis of treatment of amblyopia is actually first thing is to eliminate any obstacle to vision, like when there's a cataract, when there's ptosis, you have to eliminate the obstacle. Number 2 is to correct any significant refractive error. And number 3 is force use of poor eye by limiting the use of better eye, something like patching or atropine penalization, etc. And the newer techniques as well. And again, I am going into the same thing. And so prescribing actually optical correction, sometimes you might correct it with spectacles, so you have to go by the rules whether it is amblyogenic. Before you give spectacles, you check whether it's amblyogenic or not, whether the refractive error difference is so much, whether it's going to cause amblyopia. In that case, you might prescribe contact lenses. And so we have to, and also we provide occlusion or penalization. We decide what we are going to do for the dominant eye within this period. And patching has always been the most effective therapy, but it is the most struggling problem, and the parents are struggling, the children are struggling, and so the compliance is very poor sometimes. So there is this is the flow chart actually. They said when there is a diagnosis of amblyopia, first we treat the refractive error, and we follow up the patient every 6 to 12 weeks until it is stable. If there is improvement, then we will continue the spectacles and we follow up. If there is no improvement and there is persistent amblyopia, So we start occluding. So first actually we do 2 hours daily patching, and so it should improve. If it's improving, we'll do the close follow-up, and we tape the occlusion therapy as well. And we have to remember that when you are doing the occlusion, always we have to do the tapering. And if it's not improving, we increase the amount of patching to 6 hours or more. And so we have to, again, if it's improvement, we do the close follow-up. And if there's no improvement, we think about atropine or atropine plus patching. And if there's no improvement on the first with glasses with the refractive error, if there's no improvement with or persistent amblyopia, we follow up them up every 6 weeks, 6 to 12 weeks until they are stable. And we can add weekend daily atropine. And if there's any improvement, so we closely follow them up and then taper the therapy as well. And if there's no improvement, we have to consider patching or optical penalization. And so again, if there's an improvement, we do close follow-up and as well as the taper the therapy. And then if there's no improvement, we consider filters and eye protection and routine follow-up care. And occlusion and about the occlusion, the optical degradation, actually patching, they have actually the PEDIG study is saying full-time patching or the part-time patching, there's a similar improvement in both. And penalization, we can use atropine 1% or home atropine 5%. The advantage of atropine penalization is we are using the atropine, and so eyes are straight. So the two eyes can work together, and it's very good for children who are having latent nystagmus. And by the way, I think I have missed there was something here. Always, if you think amblyopia, always do cycloplegic refraction, not the normal autorefraction. And the newer techniques are coming of occluding. These are called neutral density filters. Actually, those called Bangetta filters, they are a bit expensive, but they are very effective. And it's because the compliance is good. And other thing is they are increasing the binocularity as well. And there are newer techniques like liquid crystal glass. They provide electronic controlled occlusion of the non-amblyopic eye in the form of intermittent flickering shutter. It switch between on or occlusion or the off or the light transmission. So the flickering interval can be adapted to the depth of the amblyopia, the strength of the treatment, and the patient's age. These glasses do not produce the side effects seen in occlusion therapy like skin patches, and there are no cosmetic blemishes, and compliance is good and acceptance is good. So this can be used in patients who are having alternate treatment between the children between 3 and 8 years of age with moderate amblyopia. And this is how the liquid crystal glass looks like. And surgery, actually when you come to surgery, cataract surgery, they are saying when there's a visually significant cataract, which is the 3 millimeters or more wider cataract, and it can be a congenital cataract, we remove the cataract within 4 to 6 weeks. And if the cataract is bilateral, if you are not going to do surgery in one go, then you have to do the bilateral interval should be less than 1 to 2 weeks. So should not be more than 1 to 2 weeks. And the traumatic cataracts in children who are less than 6 years old should be removed within few weeks. And we have to do what is called the ptosis correction. If the visual axis is occluded, we have to do the ptosis correction. And surgery for corneal opacities also should be done. And if there are vitreous opacities occluded in the visual axis, we have to do vitrectomy. And there are what is called when you are using the liquid crystal glasses or the dichoptic treatment, dichoptic training, actually you can use both eyes together, and you can ask them to use video games so that they will be actually happy to use that like this. And so the two eyes are separated, but at the same time they are using the two eyes together as well. And they were trying to keep the patient's engagement high and with video games so that they do the therapy as a task. And these are this is also another type of video game they have given. And the vision therapy is a newer type of thing. They have said there are modern vision therapy treatments given, and they are described as monofixation in a binocular field. And so the monocular fixation targets must work together to see the non-obstructed binocular field. So in conclusion, amblyopia can be treated successfully, and the recurrence of amblyopia also has been reported in about 67% of patients. And trial of patches still remains the first line of treatment, and the dioptic therapy can have added advantage in cases of recurrent and refractory amblyopia. And also when there is a recurrence also you can use the same thing again, patching and dioptic therapy as well. And so refractive correction should be based on cycloplegic refraction, and after cataract surgery provide spectacle correction as soon as possible. And anisometropic and ametropic amblyopia may resolve with refractive correction alone. And refractive surgery is a question. Refractive surgery, and there's a new technique where they are doing what is called electromagnetic stimulation of the brain. So that is, I think I heard it is available in USA. Soon it may come to Sri Lanka. And this is for the photorefractive keratectomy. This article which has come up, anisometropic amblyopia, photorefractive keratectomy can be done. And it's safely performed with anisometropic amblyopia. And so visual acuity and the stereopsis has improved in most eyes, even in older children. And it has important role in management of anisometropic amblyopia in non-compliant children. Yeah, so that will be the end of my story. Thank you very much.